This is a pretty important topic in my opinion because a lot of us do a lot of both of these things and they both interact very well. So interesting topic. I am going to make this fun. So everyone, if you need to stand up too, you need a little break, like this is a good time, like stand up, shake your feet, move around a little bit. We're going to try and get some interaction here as well. And hopefully they can get the slides up like we did this morning because there's a bunch of audio stuff I want to have fun with for you guys. So we're going to talk about glaucoma and ocular surface disease. Who treats glaucoma? Great. Who treats ocular surface disease? Great. These things go hand in hand very oftenly. So I'll give you some numbers and things like that, but I think you've all seen this, right? What's the biggest commonality between these two things? What kind of patients have glaucoma? Young patients? You see a lot of pediatric glaucoma in your practice? Because if you do, you can have them and keep them. I don't want that. Older patients, right? Biggest risk factor for glaucoma is probably age. 8% of people by age 80 have glaucoma. Ocular surface stuff, same thing. Yes. So again, this is me. My email's up here. Take a picture if you want to. It'll be on the last slide too. I'm always willing to chat and talk about things. So getting into it now. If you just want to advance it yourself, that'd be fine too. This is my disclosures. And so what are we up against? What is this stuff? So obviously, dry eye disease, you're all very passionate about it, most common. 30 million Americans with ocular surface disease in America. 3 million with glaucoma. So I always like to say if you've seen 10 glaucoma suspects, or if you see one glaucoma suspect in a day, so maybe say 2, well, you've probably seen 20 or 20 dry eye patients. So for every glaucoma suspect, you're rechecking their OCT and things like that. Remember, you've probably seen 10 dry eye patients, and I hope you've treated and addressed their disease as well. So increases with age, as well as many other things here. The anxiety, depression, mental health conditions we talked about a lot, and that shouldn't be underrated in glaucoma either. These patients have a sight-threatening condition. That's a very scary thing for somebody to tell you might lose all your vision, especially when they have moderate and severe disease and start to notice that they're losing vision, especially with age. This is a scary time for people and a scary thing. Eye drops, we're going to talk more about that, but are they a blessing or are they a curse? So even artificial tears, are we making things better or are we making it worse? And of course, all the environmental factors, the winters, the exposure to various things. So lots of ocular surface disease risk factors that also overlap into the glaucoma thing. About 60 million people worldwide with glaucoma, 8% of people by age 80 like we talked about. Age, diabetes, migraines, we always talk about vascular sides. Migraines has been associated with ocular surface disease as well. So maybe pseudoexfoliation, we have plenty of that up here. And there might be some relation, there's something different going on with the proteins in their eye, and it's a systemic condition, so there might be different things going on in pseudoexfoliated patients in their meibomian glands, so who knows? And inflammation, what about inflammation? We know it's part of ocular surface disease, but what about glaucoma? So coincidence of ocular surface disease and glaucoma, I found these numbers very useful and helpful. The prevalence of OSD increases in glaucoma patients, reaching about 50% of patients. So every other glaucoma patient you see has ocular surface disease. So if you need a referral source for ocular surface disease, just set up next to the glaucoma center and just see half their patients. SPK, as high as 54% in some studies of glaucoma patients have staining. Does anyone find that high? No. I think Trattler's phaco study, he had like 80% of cataract patients having staining. So pretty common thing, and is that mild dry eye disease? So if we have corneal staining, we're probably past that mild dry eye disease already. And tear breakup time, Schirmer scores, abnormal about 60%. So these patients have significant ocular surface disease. back to inflammation. We know ocular surface has long-standing roots in inflammation. What about glaucoma? Is glaucoma inflammatory disease? Trying to get you guys to think a little bit. I know we're getting late on Sunday. But there's a growing body of evidence suggesting that there's neuroinflammation in the optic nerve of glaucoma patients. And this is part of the reason they're developing this optic neuropathy. So how are we treating that? Well, some of the things we use, talked about this weekend, azithromycin has been used for meibomian gland disease, orally and topically, but also has been used in stroke patients to help with the apoptosis and neuroinflammation. Minocycline, same thing. We use it all the time for rosacea, meibomian gland disease, corneal thinning issues, those rheumatoid arthritis patients with ulcerative keratitis that's thinning, can be protective against that inflammation. Maybe it has a role in glaucoma as well, and immunomodulation. Maybe someday we'll be prescribing something to the optic nerve to manage the inflammation there. So maybe we're treating both conditions when we're targeting inflammation. So inflammation is definitely the enemy of the optometrist. All right, so glaucoma therapies and treatments and ocular surface disease. What are we going to talk about here? Anyone? You guys quiet? What? Yeah, look at the scale. Yes, BAK. So let's have some fun. All right, yell it out if you know the song. And feel like you're being a little punny on Sunday. Okay? Should be going. Back. You kind of blew it for me. This is what we practiced this earlier, but it should be playing right now. Nope. All right, so I would love to, but I could probably play the slides on my phone. Let's try it one more time. I really tried, guys. I'm sorry. Came down this morning. I made them use my own computer. All right, what do you know about BAK? It's what? It's toxic. It's evil. It's the devil. Have we all been taught that? How many of you have heard this before, right? Back is bad. Yeah, it is. It can be. I will go on kind of a bit of a rant here in regards to back. But, I mean, how many patients do you have on back-preserved glaucoma drops that do okay? Right? So I don't think it's the do-all and end-all. I don't think it's going to make your eyes fall out of your head. Let's just go to the slides. Oh, you had it there. You win. I want a picture of you next to that slide after the show. Okay, how about this one? Very good. That was the quickest I've seen in a long time. Backstreet is back. B-A-K, right? All right, here we go. This one I think is a little slower, so don't get too excited. Good. Good. You guys are good for Sunday? You guys are doing good. Back is in the USSR. Keep it there, right? Mueller was over there checking on that, I think, this weekend, so. There we go. We got some Beatles fans in here. That was quick. Get back. Get back. You got to get that back. Get it out of that eye. Very quick. These guys are good. I need some more from the back here. Kanto, come on.
I'm thinking. I'm old.
It's not good news if your baby's got back. Little country theme. How about this one? Come on. Where's the Iowa? Oh, she's out of here. Anyone? I got you? No country fans up here? It's Kenny Chesney. I'll give you a hint. Back is in the title. Get your pickup truck back is not correct, but I like the effort. I go back. I go back. Good. You guys are good. You guys are good. You're doing well today. No, close. X-Swift. T-Swift. Ex-girlfriend of somebody I don't know. Close. Yes, T-Swift. There he is. We're never, ever getting back together. Do not even think about it. There we go, right? Little Tom Petty, rest in peace. Great musician. And you know what? One thing he did in his career, he did not back down. This might be the... Come on. It's an oldie. Johnny Cash. Who is he? Close. The Man in Back. Oh my gosh, look at this poor guy. The Man in Back. So I get to play the Man in Back here today a little bit, but awesome job, everyone. Love to get your pictures next to your slide if you want it on social media. But yeah, back rant. Everything is a balance. So back is something we need to know about, be aware of, but it's been in drops for a long time, so I will go against myself a little bit. So quaternary ammonia compound, bactericidal, bacteriostatic, and a surfactant. So it destroys cell membranes. That's how it works. That's how it preserves that chemical by destroying cell membranes of bacteria and other things. It's indiscriminate, right? So it kills whatever it touches. Epithelial cells, bacterial cells, it doesn't care. So back exposure is an independent risk factor for ocular surface disease. And it is also a detergent. So we want this nice oil layer on the surface of our tear film, right? Well, what does detergent do? Removes oil, cuts oil. Do you ever remember that Dawn commercial where they had all the oil from the greasy pans and they put Dawn on it and it would just woo? Well, that's what we're doing to our ocular surface when we're introducing back. So it's a detergent effect on the lipid layer, especially common in our generic medications. So it's pro-apoptotic, it's going to damage and kill cells. Oxidative stress, we were talking about stressors and everything for our ocular surface. But those oxidative stresses are similar to those found in the trabecular meshwork of glaucoma patients as they age and as extracellular matrix changes occur in that. So this is similar to what's going on in the trabecular meshwork of glaucoma patients, and then we're inducing it on top of that. So it's a lipophilic molecule that can penetrate the eye very well. I found this really interesting. Levels of back can be found in the conjunctiva up to 1 week after administration of a single drop. So you put it in there, it's not going away. It's penetrating the eye very well and sticking around. So it's been found in the trabecular meshwork in rabbits and eyes and also in humans. So it's penetrating all the way to the trabecular meshwork. At high concentrations, injections of back, whoever did this is really cruel, right? But subconj injections of back cause cell death, inflammation, and increased IOP. And we think about those chemical injuries, those alkali injuries that we see. What's one of the things we do when you see those patients emergently? Check their eye pressure. Because if those chemicals get to the trabecular meshwork, they'll have a pressure of 40 or 50. So it'll kill their trabecular meshwork. So if this is a chemical injury, if you think about that, or a chemical insult, we might be damaging or affecting the trabecular meshwork. And as glaucoma doctors, we should care about that, right? So what about the medications themselves? Prostaglandins. What is a prostaglandin? Well, it's an inflammatory mediator. Where do we get this idea for prostaglandins and lowering eye pressure? When's the last time you saw a uveitis patient? I always see them when they come in, worked up by the technician, and you can always tell because one eye pressure is 20, the other eye, the red eye, is higher or lower? Typically, right? Lower, like 10. So, oh, you have a red eye and your pressure's lower on that side? Well, you probably have uveitis. You can just see that looking at the chart before you go in the room. Inflammatory mediator that can also increase outflow through the uveoscleral pathway. It also stimulates expression of MMPs, hydrolyze extracellular meshwork, and cause inflammation. What about alpha agonists? We're talking about that a little bit too here. Brimonidine. It has some allergenic and pro-inflammatory factors. Ahmad was showing a picture of a patient with follicular conjunctivitis from brimonidine earlier here. So it also can induce a granulomatous uveitis, and that can increase IOP. And there's case reports of increased IOP with use. So it's approved for lowering eye pressure, but in some patients, it makes it go up. So especially when you're using combo drops and things like that, that's something to keep in your mind that not everyone reacts well to this medication. And I always say that, when you see that allergic reaction to those glaucoma patients, this is one of the big offenders, especially with the generics forms of this medication. So what do we give our dry eye patients a lot now, right? Lumify. So who uses Lumify in their ocular surface disease clinics? I do. It's brimonidine, very dilute. Talking about it a little bit earlier. But yeah, we used to mix up the magic drops, 3 drops of it to a bottle of tears. But it's for eye whitening, and a lot of times our patients come in and that's what they want really bad. And I think it's a nice tool to have, but we also have to remember that this brimonidine might have some ocular surface disease contraindications, and also it's preserved with BAC. So maybe not the best thing for our ocular surface disease patients. Again, life's a balance. Maybe a good initial thing to get them through until you can get their surface under control, but remember those other things that it could be doing. So medicamentosa, so iatrogenic, allergenic response to therapy. So what do we see? Hyperemia, edema, follicular reaction, especially with those alpha-GAN patients. And here's some statistics for medicamentosa in various glaucoma therapies. So prostaglandins, 1.5%, CAIs, 3 to 4, beta blockers, 11 to 13, and alpha agonists, 11.5. So what if you combine those two? What if you have ComboGAN? You have a beta blocker and an alpha agonist. So that kind of helps you point out, like, okay, this patient is having medicamentosa reaction, they're having an allergic reaction to one of their medications, and maybe then a bunch. Hopefully this helps steer your decision-making on what to take out first. Again, pseudopemphigoid, form of medicamentosa. So we talk about true pemphigoid, cicatricial pemphigoid. This is pseudopemphigoid is a diagnosis of exclusion, but has been explained in several cases of 28.3% of all pseudopemphigoid cases were related to topical glaucoma medications. So keep that in the back of your mind. If you're seeing someone and you're like, oh my gosh, you have pemphigoid, you definitely need to rule that out, and it's quite a workup, but might be related to their glaucoma medications as well. So seeing that cicatrization of the conjunctiva. So this is not out yet, but this is Dr. Brett King at Indiana's table that's going to be in modern optometry soon. But I thought I would share it with you all because it's a pretty good list of all the medications we have for glaucoma now, and some of their things, like latanoprost or Zelprost being a BAC-free. It's preserved still, but it's a BAC-free form of latanoprost. And more. This is in your slides if you need it. I'm going to kind of run fast because we're running behind. All our glaucoma options. And what about these? What's the best thing about these as far as the ocular surface? Come on. Yeah, they're pills. It's oral, right? So it's not going to hurt your eye as much. And Repressa, the new kid on the block, Rocklatan coming out soon. These are this is from, both of these are from Glaucoma Times. One was by Leslie Odell. And medications with their back concentrations. So there's been some pretty good evidence and studies that showing like back-free is really a good option and less ocular surface disease. Preservative-free versus back-free, and by back-free I mean preserved but not with back. Probably pretty equivalent. So these other preservatives, pretty good option, but there's still a preservative in there. So when they say back-free, it doesn't mean it's preservative-free. There's a difference there. And then these are some of the other ones that are newer to the market, and their back concentrations as well. All right. So it's still in there. So ocular surface and the optic nerve. So when you see a patient with a glaucomatous optic nerve, what do? What's the first thing you order? OCT. I want to image that optic nerve. I'm worried about glaucoma. Your pressure is borderline. I want to know what your optic nerve is doing. What do you do when you're seeing a patient on Plaquenil? You have Sjogren's, you have dry eye, you're taking Plaquenil. Come on. Yeah, macular OCT, 10-2 visual field testing, right? How do you track the effectiveness of your therapy? What do you do when you put someone on Travatan or Lomagan or whatever medication you decide is best? You have the pressure before and after too, right? So how do you know there's been a change? You track it. So do you prepare LASIK patients for changes in their ocular surface? Do you tell them this might make your dry eye worse? Sometimes? Good. Yeah, if you don't, well, it just makes more work on the back end. So you can decide if you want to work on the front end or the back end. Everyone likes to have their choice in the matter. So I think you guys are picking up what I'm putting down here, that if we know we're going to have a glaucoma patient and we're going to induce changes in their ocular surface by adding a medication, should we be testing their ocular surface beforehand to track for changes, to watch for this condition that we might be iatrogenically inducing? So this is looking at topical anti-glaucoma medication effects on the ocular surface. A recent article. And of note, decreased tear film stability, decreased T-butt, elevated osmolarity were both observed in eyes treated with topical glaucoma medications. This was associated with increased redness and eyelid margin changes. We just had a whole lecture on eyelid margins. So these glaucoma medications might be adjusting these things. And it suggests that there's an inflammatory mechanism to play a role in that. So if we know our glaucoma therapies might cause these changes, maybe we should work up our dry eye patients, our glaucoma patients, for not only their optic nerve, not only their visual field, but also their ocular surface, because they probably already have concomitant disease. And if they don't, we might be inducing it. Mrs. Jones, you have glaucoma, I'm sorry. We're going to get ahead of it, we're going to treat it, I'm going to protect your vision for the rest of your life. I also need to preserve your ocular surface, because maybe you have some signs of really dry eye, or this medication that I need to give you to treat your glaucoma might cause dry eye, and I want to watch for that in the future. All right, so influence of treating ocular surface disease and IOP. So what if we have patients that have glaucoma and have OSD? What happens if we treat their ocular surface disease? So this was a case series of patients referred for filtering glaucoma surgery. I want this patient to have a TRAB. Their glaucoma is on maximum medical therapy. They are uncontrolled. I need help. Please do a TRAB. And the treatments, they just said, okay, we might do a TRAB, but instead, we are going to switch them to preservative-free equivalents of their glaucoma medications, switch them away from allergic treatments, or look for allergies in some of the treatments they're having. switch their class of medication with a better safety to something with a better safety profile. And we're going to treat their ocular surface, especially their lid. We are going to treat their MGD. 86% of patients, right, with II. So what did we find by treating meibomian gland disease in patients with end-stage or uncontrolled glaucoma? So at 6 months, they had improved ocular surface. Good, your meibomian gland treatments worked, right? Associated with an intraocular pressure decrease or stabilization, even though their glaucoma medications were removed. So you can take people off their glaucoma medications and lower their IOP by treating the ocular surface. So if we have a happier, healthier eye, their pressure goes down. The IOPs decreased from 23.75 to 15. The mean number of IOP medications was 3.7 to 2.8. And staining, corneal staining, fluorescein staining went from 1.7 to 0.4 grade. For 2 patients, the IOP wasn't reduced enough, and they did have a filtering surgery. So when we're sending these patients, just like everything else, a cataract patient, we want their ocular surface to be pristine and ready for surgery. Same thing with glaucoma patients. If you need surgery, prove it. Let me do everything else. Let me switch your medications. Let me treat your meibomian gland disease. Maybe that's enough. So who wants to, who wants to do surgery on a sick ocular surface? So these glaucoma surgeons, it's our job to set them up for success, right? Just like we do in LASIK, just like we do in cataract surgery. These people need to be set up for success. We need to make the surgeons look good, you know? That's our job sometimes, at least mine. I got to make you look good. So decreasing inflammation, decreasing back load, treating inflammation with lifitegrast, cyclosporin, maybe even NSAIDs. Acuvale is a preservative-free NSAID. And steroids, maybe these microparticle, safer steroids will have more bang with less medication and less preservative, hopefully. So decreasing inflammation, also tear stimulation, true tear, a drop-free, drug-free way to improve the tear film, lower osmolarity, decrease inflammation, treat that without the patient having to put another drop in. So something good without having to put another drop in. What about filling the swamp? I think that was Laura Perryman. Filling the swamp, I think she was saying drain the swamp, but I'm filling the swamp. What about plugs? Of course, treating the lids, LipiFlow, all our options now, pulse light. And also, don't forget about those contact lens patients. Melissa, do not forget about the contact lens patients, right? All right. So if they're contact lens wearers that have glaucoma, preservative-free, daily disposable, all the things we went over. And allergic conjunctivitis. Pollen count went up like double up here like in the last 2 days. So decreasing inflammation again. What about a medication vacation? If it's iatrogenic, taking the break from their topical drops, giving them a week off, getting their surface back to oral. Maybe oral CAIs have an option there that we can go to an oral medication while we're getting them back to normal in severe cases. Just a thought, trick, tip. All right, what about plugs? Back to this. There's a study on this. What do plugs do on the ocular surface in patients using, this was just topical prostaglandin analogs. And what did they find? Punctal plugs improved subjective and objective measures of OSD and resulted in reduced pressure in patients. Why would they have reduced pressure? There you go. Increased contact time, right? The medication's not going to go down the drain. It's going to sit on the eye longer. But in this study, it showed a tear breakup time increased, staining sore decreased, and osmolarity decreased. I think we all know and we hyped on that if we're trapping inflammatory material on the eye, that might be a bad thing, right? That plugs might make it worse. Eric said if you don't like a patient, put a plug in them and a hot eye, and they'll really like you a lot. But if we've treated the inflammation, if we've addressed inflammation in the ocular surface, maybe plugs aren't a contraindication. What about surgery? SLT, MIGS, big expansion here. Should SLP be the first option for glaucoma for glaucoma treatment in patients with significant OSD? Maybe. And if we're primary glaucoma carers, and this is the best thing we can do, treaters, should optometrists be doing SLT? I don't know. What do you guys think? All right. Cataract extraction. A phaco study showed that at cataract extraction, there's a lot of dry eye disease. Same thing with any surgery on the eye. It's probably going to worsen ocular surface. So even with MIGS, cataract surgery, we have to be aware and set them up for success. Their MIGS will work better if their ocular surface is better. And trabs and tubes. What's the first most important intraoperative indication of success? When I talk to my glaucoma doc, and he's telling me about some case that I have to see over the weekend or on call, it's always like, well, I pulled back the conj, and it was just this ratty conj. And that's when I know the story is going to go south, right? Have you heard that? Ahmad's laughing. I think he's heard this one before. That conjunctiva, if it's not good, that's what they're building this bleb out, right? So if they pull this tissue back and it's all ratty and their surgery, he always complains about conjunctiva. Well, the patient didn't have good conjunctiva, so we had to do this or that. And so if we can get that conjunctiva to be better, I think the patients would be more successful and we'd make the glaucoma surgeons look good. Good, so I hopefully planted some seeds. Hopefully got you thinking about things. Questions about ocular surface disease and glaucoma? Everyone's thirsty or hungry. Maybe a little bit of both. Awesome. Thank you for your attention this morning. Really appreciate it. Thank you, Ahmad, for the opportunity to get up here and talk to these people. Really appreciate it. So I'm sure you have some closing notes or remarks.
Nothing more than to say that I really appreciate you guys being here, and really appreciate you guys being here and taking time on your weekends. I'm committed to trying to bring the best, educators and trying to bring the best technology here to the extent that you all feel like it's worth your time, and go out there and enjoy the rest of the day, and thank you for being here.